Hello ladies and gentlemen. As the title suggests, what is new in nutrition? It's a very catchy title, but the topic is so huge that in a limited time frame it is impossible to cover the entire gamut of nutrition in a short period of time. So what I've done in this presentation is to focus on three key areas, namely maternal nutrition and its impact on nutritional status in infancy and childhood, the gene-nutrient interaction and interface, and potential implications for clinical practice and clinical application. Recent observations and recommendations regarding immunonutrition in specific clinical settings. In this context, I have focused mainly on the critically ill scenario because this is one area which is applicable to most organ systems and most subspecialties. Now let's look at the first aspect of these, maternal obesity and what possible impact it could have on nutritional status in infancy and early childhood. Now under this, I am discussing it under four subheadings: role of leptin in the developmental programming of obesity and hypertension in infancy and childhood, which is secondary to the maternal obesity, the possible association between maternal obesity and cardiovascular risk in the offspring, the impact of fetal nutrition, maternal nutrition on fetal programming, and the Pedersen's hypothesis, which I will explain in some detail in the latter part of this presentation. There are some very important observations regarding leptin. These have been done in animal models, but the knowledge gained from these observations may help us in potential application in the human situation. These animal models have shown that the adult offspring of diet-induced obese mice develop systolic and arterial mean arterial hypertension by 3 months of age, and this has been associated with arterial resistance and endothelial dysfunction. Very well documented fact. The hypertension which resulted from this was associated with increased visceral adiposity as well as an increase in the blood leptin level, that is hyperleptinemia, which suggests that there is an obesity related leptin mediated hypertension which acts through the central sympathetic pathways. The maternal obesity was also found to be associated with marked hyperleptinemia in the newborn, and this was during a critical period of brain development, suggesting that the effect of leptin on neonatal neuronal development in the brain is by modulating hypothalamic neuronal outgrowth during this very critical period of brain development, another fact which has been very effectively documented. Leptin has been shown to influence pathways regulating adipocyte proliferation and differentiation and is involved in nutritional programming. And there has also been observed to be an increased N6 to N3 fatty acid ratio in obese offspring, and this contributes to an accelerated maturation of the pre-adipocytes and a sudden increase in leptin levels. Now this flow chart very explicitly shows you what maternal obesity can produce in the time of pregnancy and lactation on the fetus. Excessive adiposity and obesity in the mother leads to fetal and subsequent neonatal hyperleptinemia. Over a period of time, there is an increased resistance to leptin and impaired neurotrophic action in the hypothalamus. This altered response to leptin signaling in the hypothalamus is manifested throughout childhood, and the effects are carried well into adulthood. So with this selective leptin resistance, there are two types of effects which happen. On the one hand, there is a decreased metabolic action. Because of decreased metabolic action and metabolic rate, there is also associated excessive desire to eat, and both these, excessive desire to eat and intake of food as well as decreased metabolic action, both lead to a rapid development of obesity. Along with this, there is increased activity of the sympathetic nervous system, which causes the blood vessels to constrict, and this leads to hypertension. Let's look at the effects of maternal obesity on possible cardiovascular risk in the offspring. It has been amply documented that maternal obesity and excessive gestational weight gain have direct implications on both perinatal and maternal morbidity and mortality, as well as cost of health care, and what is being described by some investigators as a transgenerational acceleration of obesity. By this is meant the effect of the obesity passes right from the mother through the offspring, right from the fetal, neonatal, early childhood, right into adulthood when the offspring becomes an adult. And there is a widespread concern that exposure to such obesity in utero and in the perinatal period may lead to obesity and related disorders in childhood and later life. What is the effect of fetal programming? Here, it is best understood by exploring the link between maternal obesity and development of hepatic steatosis, fat accumulation in the liver, in the offspring. There is a clear link which has been demonstrated between ectopic accumulation of lipids in tissues and development of insulin resistance in these tissues. The root cause, which contributes to a very well-known clinical condition, non-alcoholic fatty liver disease, NAFLD is the abbreviation, is due to an excessive accumulation of the substance triacylglycerol in the liver, which produces this non-alcoholic fatty liver disease and associated insulin resistance. And there is recent evidence which shows a very good correlation between hepatic triacylglycerol content in adolescents and sensitivity to insulin, and this was an effect which was independent to whole body and visceral fat mass. All these observations suggest that the programming effects of maternal obesity and diabetes on the liver of the offspring can significantly influence sensitivity to insulin in young adulthood. What is the Pedersen's hypothesis? Now, we all know about the Barker's hypothesis, namely an mother who is anemic and malnourished, who has chronically been undernourished, produces an infant with a low birth weight. Now, in the first 2 years of life for this infant born with low birth weight, when you aggressively intervene nutritionally, then you may end up producing more harm than good. What you end up doing is, you may, if you intervene appropriately, you produce an appropriate weight for height. If you carry on this intervention beyond 2 years of age and you start your intervention around 2 years of age or beyond, all you will achieve is producing an overweight but stunted child, because any effect on improving height growth is best achieved before 2 years of age. After the age of 2 years, you may produce overweight in response to that height, and this is more harmful than helpful. That is the Barker's hypothesis, which we are all aware of. Another important aspect, the Pedersen's hypothesis, which simply put means that an obese mother can produce an obese fetus and an obese neonate, which leads to obesity throughout childhood, and these may end up becoming obese adults. So, essentially what has been found in this situation, where maternal obesity produces obesity in the infancy and young childhood, is something which has been well recognized in the Western world, and it would not be wrong to assume that even in this part of the world, South Asia, where obesity has been shown even in low socioeconomic community, there are enough studies to show that obesity is not confined to the affluent, it is also found in the low socioeconomic status. Even in such situations, it is important to put this into clinical practice and recognize the importance of these observations. What actually happens is, elevated circulating maternal concentrations of glucose, fatty acids and amino acids in the obese mother lead to fetal overnutrition and hyperinsulinism, which in turn results in fetal overgrowth and increased fetal adiposity. From a biochemical standpoint, the main metabolic alterations which are seen even at the fetal stage are hyperglycemia, hyperinsulinemia, and hyperleptinemia. And in addition to adipose tissues, the other tissues in the body which are involved in regulation of appetite and body weight, which includes the hypothalamus, are also affected. Now, moving on from the effect of maternal nutrition on fetal and infantile and childhood nutrition outcome, we move to another important area, the gene nutrition interaction. What effect does genetics have on nutritional status in subsequent stages of life? In this regard, it is important for us to understand what two important terms mean: NUTRIGENOMICS and NUTRIGENETICS. NUTRIGENOMICS is the role of nutrients and bioactive food compounds on gene expression. On the other hand, NUTRIGENETICS is the science of the effect of genetic variation on the dietary response. Now, there are three important factors which have been shown to influence the practical utility of NUTRIGENETICS and NUTRIGENOMICS in clinical nutrition and dietetic practices. These observations are that there is a great diversity in inherited genome between ethnic groups and individuals, which affects nutrient bioavailability and metabolism. This is something which we recognize and which has been well documented. The other important observation is that the considerable variation exists among individuals with regard to food and nutrient availability, and also choice of foods based on ethnic, cultural, geographical and taste perception differences. There is no better example than our own country, India, where the food habits and lifestyle practices between the north and the south of India are so different. There is so much diversity. In the north you have a wheat eating population with different types of spices they use in their diet. In the south it is predominantly a rice eating population with different dietary habits. Malnutrition, be it undernutrition or overnutrition, both ends of the spectrum, the same thing is applicable. It can affect gene expression and stability of the genome. The genomic instability may result in mutations at the gene sequence or chromosomal level, which alters dosage and expression, and this in turn results in abnormal phenotypes. And optimal health outcomes can be achieved if the nutritional needs are customized for a specific individual, taking into account both the inherited and acquired genetic characteristics which are dependent on important factors such as the stage of life, individual dietary preferences and overall state of health. To quote an example, most of us are aware about the recommended dietary allowances for Indian children, but these address the community as a whole. These are blanket guidelines and recommended allowances for the general community as a whole. They do not address the issue of customized nutritional needs, whereas the gene nutrient interaction helps us to understand how to tailor the nutritional requirements for a specific individual. Now, two other terms in this regard, epigenetics and epigenomics. Epigenetics is the science which studies the processes that determines when certain genes get activated or are inactivated. The terms which are used in genetic parlance are turned on and turned off. Epigenomics, on the other hand, is the analysis of the epigenetic changes which occur in a cell or even the entire organism. When certain genes are silenced epigenetically, and these are genes which normally protect an individual against a specific disease, when these get silenced, that individual becomes more susceptible to that specific disease in later life. A very practical example of such a situation is development of cancer in susceptible individuals. Here, the normal cells which proliferate in a particular way are silenced, and they end up proliferating in a very different way, more rapidly and abnormally, which leads to the development of cancer. This is what the cancerous cells are. Epigenomics involves gene-specific DNA methylation, histone modifications, and also activity of chromatin-associated proteins. So, to summarize the important observations regarding gene-nutrient interaction, the ability of diet to influence flow of genetic information may occur at not one but multiple sites of regulation. Research on the gene-nutrient interaction has shown how genes influence food preferences through sensory, reward or energy homeostatic pathways. And establishing a genetic basis for food preferences may explain some inconsistencies which have been observed in studies which have tried to relate food preferences to subsequent development of chronic diseases. Now, what is the potential application of nutrigenetics and nutrigenomics when it comes to clinical practice? Take celiac disease. Here the HLA testing, most notably the HLA-DQ2 antigen and the HLA-DQ8, have implications for personalized nutrition. When it comes to obesity, which is not only an individual but also a public health problem, there is a specific gene called the FTO gene, which has numerous polymorphisms. The RS9939609 SNP is the most well known among these. This has an implication for personalized nutrition. Take Parkinson's disease. Here what happens is there is lipid peroxidation due to activation of phospholipases. Alzheimer's disease, there is a genetic variation in the gene encoding the variant of apolipoprotein E4. Colorectal cancer, you can modify it through a protective effect of butyrate in digestion resistant starch. We are all aware in this regard that 20% of normal digestive activity takes place in the large gut, the colon. Some people have tried giving a high carbohydrate diet, and that is more in the adult population they have tried it, giving a high carbohydrate diet, and that gets converted to short chain fatty acids in the large gut. Butyrate is one of them, and this is a source of energy, and it is also protective against colorectal cancer. Now, moving to the last part of my presentation, I am focusing on a specific aspect of nutrition, immunonutrition, and I am just summarizing the guidelines which have been formulated over the past 2 years, and it also shows why nutrition is ever changing and new, because just within less than a year we have 2 leading organizations in the world, 2 leading societies which have come out with practice guidelines for immunonutrition in the critically ill patient. And here we find that the Canadian clinical practice guidelines, which were just in May 2015, barely 9 months ago, for glutamine, arginine and N3 fatty acids, they said that for glutamine, the enteral glutamine should be considered only in burn and trauma patients, and there are insufficient data to support the routine use of enteral glutamine in other critically ill patients. And it was strongly recommended that glutamine in any form, enteral or parenteral, should not be used in critically ill patients with shock and multi-organ failure. On the other hand, with arginine, there was a clear recommendation that diet supplemented with arginine should not be used in critically ill patients. On the other hand, in trauma patients, there is no clear benefit of arginine supplementation demonstrable, but it has also been shown that it is not harmful. So, this is an area with some ambiguity, it is a grey area, whether or not arginine is really helpful in the trauma setting. When it came to N3 fatty acids, the omega-3 fatty acids, the use of an enteral formula rich in omega-3 fatty acids which contain fish oils or borage oils and antioxidants are strongly recommended and must be considered in patients with acute lung injury and acute respiratory distress syndrome. So, in the pulmonary critically ill patient, there is a big role of N3 fatty acid supplementation. And yet, here is a classical example of how new nutrition is and how quickly the change can come about. This is all May 2015 I have talked about, and here we are, January 2016. the guidelines of the American Society of Parenteral and Enteral Nutrition on immunonutrition in critically ill. It can be best summarized with two statements. The role of immunonutrients in critically ill patients must be limited to the patient with traumatic injury and the patient in a surgical intensive care unit. The routine use of immunonutrients in the medical intensive care unit, including the use of omega-3 fatty acids in acute lung injury and acute respiratory distress syndrome, is not recommended. So, I conclude this presentation, ladies and gentlemen, with the following observations. In clinical nutrition, recent developments relevant to both preventive as well as therapeutic nutrition are important. A clear understanding of maternal nutrition influences impacting physiological and biochemical changes in the fetus and early infancy will help prevent long-term effects of such nutritional intervention in later life. In addition to drawing up nutritional recommendations for the general population, such as the RDA, it is no less important to understand and appreciate the potential benefits of tailor-made or customized nutritional intervention in a specific individual from the practical standpoint of both prevention and treatment of disease, and in this regard the science of nutrigenomics and nutrigenetics have shown a lot of promise. It is equally important to keep updated with the most recent advances in nutritional intervention in specific clinical settings, although the evidence may require modification in approach to nutritional intervention from time to time. Thank you all.